Thank you very much and good evening. Because I've changed my presentation actually after looking to the program. I've changed it to this one because a lot of pot and a lot of side branches, although the one that I was preparing was interesting with very difficult technical challenges, but I've changed to this one. I think it's better. Okay, let's go with our patient today. He's a male-aged patient. 65 years old, he's a smoker, dyslipidemic, and having a family history of ischemic heart disease running in his family, all his family. He presented with acute coronary syndrome, inferior STEMI, blood pressure is 70/50. This was after midnight, as usual. The previous history, it was me. I did him a PCI, lead and RCA 6 years earlier, and his ECG showed ST elevation in the inferior leads with severe reciprocal depression in the anterior one. His echo at the emergency room showed inferior severe hypokinesia as well as inferior and anterior also hypokinesia. Ejection fraction was at that time preserved about 45%. Past history was irrelevant for something, but of course because of his smoker, he has repetitive attacks of bronchitis with COPD. Let's go for his angio. We'll change a little bit. I need an action a little bit. We'll discuss. Here is his angio, as you can appreciate. The LED, there is ostial and instant restenosis, okay? The circumflex a long lesion, as well as a ramus or early diagonal, as you would like to say. Here is his angio with also malformation, local focal aneurysm. This is the presentation, thrombus in the RCA, and he's in shock. So the patient is in shock, 70/40, after midnight, instant restenosis in both. This is thrombus, late thrombosis instant after 6 years, and the patient blood pressure is 70/40. How would you manage? How would you go? What are the plan? Yeah? Yes? By instant restenosis, thrombosis. What do you think? And still there is STEMI flow, but the patient is in shock. He's in continuous pain, yeah. Okay, what would you do? Yes, with the thrombus inside. Okay? Predilatation, no thrombus aspiration. That's my question. There is a thrombus, instant restenosis, 6 years earlier this stent. How would you go? And what are your plan later on? Are you going to do all the vessels in the same time? I need an action. I need the strategy. Yes. Decision of bypass or no, you should answer the questions at 2 a.m. because it will differ a little bit. Your strategy, you're going to continue first with complete PCI or reverse the shock by the right coronary and then discuss for CABG. This is my question.
What the guidelines say, right? Do it doesn't mean cut the shock say that only one vessel. It doesn't mean no complete reversal. By doing now, you change your practice of the guidelines.
I think sometimes we should not follow the guidelines. Because of sometimes there is poor study in modifying the guidelines. We are seeing the case of to modify the guidelines. It's set for people stop. It's not for people stop. Some people stop because of the poor study. So in this particular case, I don't know if the patient has the second elevation in the inferior territory.
No, it's ST elevation in the inferior with severe reciprocal in the anterior leads. And it's left main equivalent. It's not left main, but trifurcating, yeah, critical lesions.
So I will use GTP first.
Yeah.
Intraorbital top.
Yes.
Thrombectomy of the right cardiac artery. Then optimization of the stent, 20% of that perfectly important. And then I will continue with, if the patient is really in shock, I will continue with the other lesions. So very tight synthesis of the LSD, very tight synthesis of the diagram.
Okay.
And so I
Because
will
he
do,
is shock.
yeah.
If you open the right coronary, the blood pressure will gain. The patient is not in shock. You stop.
Okay, we have in the guidelines emergency CABG as class 1A in shock. No, this patient. Because of 2 a.m. or because of... okay, it's very high. Because it's class 1A in the guidelines. Management of shock. Yeah, cardiogenic shock.
It's a very difficult case. When I see a patient with an inferior infarction and cardiogenic shock,
Yes.
I will normally, on the way to the cath lab, try to rule out right ventricular infarction to know if this is true cardiogenic shock or failure, because this could make a difference.
Yes.
And when I see this angiogram with 33 flow of the right coronary,
Yes.
I wonder why is the patient in shock.
No, because the left system, there is no flow. It's 98% in the LAD. Instant restenosis, the 95.
Be certain that this is really cardiogenic shock. Because if it is an RV,
Can you appreciate here? Huh? It's proximal.
The other thing is support. We don't have an impeller in Egypt.
Yes.
Working on those extremely hypotensive patients. I know the data doesn't support that, but I still like using it.
In case of inferior part, inferior ischemic, as you said, the cardiac shock will go to intervention to the cardiac artery first, then to the other if there is ischemic shock. But I think in this particular case that we have a big thrombus in the right coronary artery, and the right coronary is already open with a teeny free flow, and there is risk of occlusion of this right coronary artery when we go to intervention for such a heavy thrombus burden. And we may make the condition more worse with intervention of the right. I would agree with Dr. Kenny that I give this patient a full medical treatment, for example, a triple antibiotic therapy, intravenous, like 2 to 3 minutes in addition to dual antibiotic therapy. I would put intra-aortic balloon if I don't have an impediment, and I will do my best to stabilize the patient without doing intervention for such a very big thrombus in the right artery, and I have activity flow in such right artery.
Thomas, Amr Zaki.
So in my experience, I never see such a patient going to surgery emergency.
Yes.
So I think we have to manage the right in emergency.
Okay.
It's a complex, even the right, it's not an easy PCI, so I will go with a strong support, not a GR catheter, but and I will.
This is radial approach.
Yeah.
Yeah.
Radial approach is okay if you have good support, it could be nice. I will put a wire, try to perform a thrombectomy first without medication.
Thrombectomy. Yeah, okay.
And I will also facilitate the angioplasty with anti-GP3A.
Okay.
And if the patient is not in shock, I will not go for the left system
Okay.
at night.
Okay. Okay. Now inotropes or not?
Yes, I don't know.
In the cath lab?
In the cath lab, before you impart the trauma angiogram,
No.
this patient moves on noradrenaline.
No. We took him very rapidly to the cath lab. No, but inside the cath lab, at this moment, I ordered the anesthesias. It was 2 a.m. in the morning, and we started Levofed. Just now.
Okay, because I think that with some good contractility and see the whole.
Actually, we did an emergency echo screen in the emergency room, it was ejection fraction, it's 45 to 50. It is not so bad. Okay. So Hani was right a little bit because maybe it's reflex, but his blood pressure was 70/4.
So I think also a lot of the technique that I'm going to, this is a material I have to fix this right normally.
And then later on, we'll see for the left system. Okay. 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 Okay.
If you talk about the guidelines, so I think you can see capital is physical. If it's not physical, then it's not. The second option is to do the intervention, but it should be under which is not there for intra-aortic balloon.
Which is there. We have an intra-aortic balloon in the cath lab.
So intra-aortic, so you can fix the RCA lesion either by thrombectomy and then to primary side ventricle and again to stabilize the data.
Okay.
Come back to the guidelines, emergency cabbage.
It's class 1A, yeah.
We don't have primary PCR, no, we have a recent ileal infarction. Have a multi-vessel thrombus. Who is going to let these patients in emergency? In any hospital. The mortality is very high. The guidelines say that open, even the left vein, open the left vein.
Okay.
So the problem that we open with other vessels or to put in the aortic balloon. Other vessels had block or on index hospitalization. The guidelines said first do the culprit, the patient will survive with index within the index of hospitalization up to 28 days. The second, the complete. The second, no one's aortic balloon except in very special cases. We don't have to pay that, but in aortic balloon. So culprit shock for 3 years, even if there is no aortic balloon. This is the guidelines, but not only 100%.
We'll take another 15 minutes like that. Okay.
There is nothing in the data that says that you in cardiogenic shock, we do the chart and see whether the shock will be
yes.
corrected or not, because the patient would like a second. We will not wait for you until you see all the data. The data. The guidelines is not saying do the calculate only.
Do the calculate in the same time. But within few days,
the guidelines routine.
Without shock, complete trial, plus 28 days. With shock, the patient recovers, plus blood pressure degree. Don't do it at the same time.
Yes.
هي كانت عشان نقولها هي كانت تقول كده كان زمان بتابع كل ليله في البريك بس لا هو كان يقول the second third day ليه؟ عشان الاماونت اوف لايف والديوريشن والبروسيدرز especially complex بنتابع other vessels.
Let us be practical in the cath lab.
Yes. Yes.
Do you think that the studies will allow the patient to recover in the cath lab? Do you think that?
Okay.
You do not. هي كده انا بقوله مش انت اللي بتحدد. هي كده اتغيرت الموديل السبيلي بعض.
Okay. It's good for discussion anyway. Yes. It's okay. Especially that we are in radial. Yeah. Yes.
Just to wire, if it goes easy and you will find that you can put a direct send.
Okay.
And I think it would be difficult to put direct send. Or put a balloon, then extremely fast.
Okay. Okay, let's go for continuation because we are in bifurcating lesion and still there is a lot of discussion later on. I'll proceed. In my mind, I was going to do the right coronary even without stenting, and this was my plan. If he recovered, I'll send him for surgery because we have a very complex left-sided lesions, in-stent restenosis, trifurcating, long lesions, and equivalent to left main. So this was my strategy without intra-aortic balloon because I'm in radial. Go ahead rapidly because even to wake up the anesthetist, he was sleeping. To get the noradrenaline, it took 5 minutes, and I did proceed very, very rapidly. And with aspiration, and actually after passing the wire, I have no reflow at all. So this helped me to go with aspiration. I should aspirate. We have a lot of thrombus, and as you appreciate, okay, the thrombus was here. It didn't pass because there is a stenosis, okay. That was good for me. Then balloon, this is 1:1, it was 3.25. And then this proximal lesion, let's go on ballooning it. And this was my final result, and the patient blood pressure came. So what's next? This is the patient, the shock has been reversed. The patient, I put him in the hospital. Next day, he was in excellent state. His blood pressure came, his usual blood pressure was 100/70, and then it came to 110/70. At the third day, we had a lot of discussion with the family. Actually, I'm managing most of the family. His brother had the same coronary lesions, and I insisted that he had to go for CABG, and he did the CABG, complicated CABG, and then I did revascularization because he had an occluded lima and occluded venous graft to the left system, and I ended by left main stenting to his brother. So he remembered me, he told me, I'll never go for surgery. I'll never go for surgery. I'll never go for surgery. Then I said, take your time. Now you are in a good state. I won't go in hospital stage. I will postpone you because I did a balloon and I didn't have a stent in the right coronary, and I'm preparing you for CABG. Let's get it after 1 month or even 2 months. And the patient disappeared. He was very good and came to me after 2 months, told me, doctor, I still have an angina because I stopped smoking. I've never walked. But now while I'm walking, I have a chest pain. Please go and let's see what, I'm not going for CABG. So what's the strategy later on? After 2 months, the right coronary was still no restenosis in the proximal. Distal, which I left, the PL was improved a little bit. So I instead go for the left. So what's the strategy for trifurcating lesions now? We are going for 1 stent, 2 stent, in-stent restenosis, 3 stents. Okay. Here is the view. We had the other views from the previous coronary. Okay. No, I'll take it. Okay.
I think you have to consider it as a bifurcation, not a bifurcation.
Why?
Two major bases have
The ramus was reaching till the apex. Okay. When you compete with the surgeon, try to do complete revascularization. No? Okay, I'll go for the angio from the start, but I'll go because I haven't. Let's go from the very start. Yes? Okay. Here is the ramus. Regard here. It's very long. Okay. So you want this diagonal to neglect it. Okay. 2 stents.
And both of them, I found that it was not a true trifurcation. It is a very high open, and after doing the BCI, the carina began to change. It appears that it is open one. For trifurcation, you are clear.
This is a trifurcation. I'm sorry, it's trifurcation.
In all trifurcation, I mean, for example, in each trifurcation, let's speak about trifurcation. Sizable trifurcation.
So as a way, I try to simplify as much as possible, but as you said, we have to offer the version, the better vascularization. So to simplify it, I will go with a large catheter, maybe
7 French. This is 7 French femoral. Yes, I've changed it here from femoral. Yeah.
I will put the 3-wire in place.
Okay.
And maybe try to treat two bifurcation instead of one bifurcation.
Okay.
Sometimes it's possible, sometimes not. And maybe considering the access, I think it's illusional to not treat the distal line. So maybe treat road crossover toward the
So V stenting. V stenting, our STS.
No.
Yes, it's okay here. No?
Maybe on the lady, but I'm not sure about the circumflex. So can you...
Okay, here it is.
Yeah.
SKS. Okay. Touching, yeah. So, okay, we're different now. We are returning. That's what was my strategy. Here is the wire. It was not so difficult to emulate the LED in spite of this aneurysm. We had to go with the NC with a wire in the diagonal. Okay. And then here's the LED, stent for LED, and wire in the diagonal without LCX. Now wire 3 wires, and this is, I took out the wire. This is took the wire, the stent from the LED, didn't deploy it. I said to myself, I'll go with the 3 and keep a balloon and these 2 SKS and the balloon inside. Yes. 2 stents. I did the stent of the LCX because it was difficult to cross, so I removed the stent from the LED. I didn't deploy it.
STS هو دي وايد انجل sizable
Yes.
وهو بس 3 what is هو you are not touching the main vessel وفي 2 stents من ال LED cell which X cell will be left main. This is needs doesn't need needs two vessels equal size because if you go for the both are touching the main vessel يبقى لازم to equal size. Am I right? Are you going to do this?
No.
Okay. Yes, I'm sure that's no. Okay.
So I think the ostium of the circ is not involved. So we can do provisional, but of course we run with 3 steps. But I think the main vessel is the LED. So okay, we stand from left main to LED. Then you have a bifurcation, which is not it's not a bifurcation. It's a bifurcation between LED and diagonal.
Okay.
As you can see here.
Okay.
And the fact that you have a good view at least is very important because I was not able to define a strategy before seeing this view.
Yes.
In this view, we have everything. So we know that it's a bifurcation LED diagonal,
Okay.
and it's a bifurcation circ LED.
Okay.
So 2 bifurcation, as it was said by Thomas. So now you can treat the 2 bifurcations. So 3 wires,
Okay.
1 stent from left main to LED.
From left main. From left main, crossover.
Yeah, you deploy the left.
No, I didn't deploy it like that. I deployed in V. This is SKS, but I've changed it. Yes, I did V stent. Here I did V stent.
So I will do a left main to LED.
Yes.
You cannot be as precise as we
Okay.
think. So left main to LED, then the pot.
Okay.
In the left main, then the pots, different pots between the LED and diagonal.
Okay.
Then we open the spot, we do a kiss.
Okay.
We
Like
send the diagonal,
okay.
and then we do the stent in the circle and do
Okay.
the kiss and the final.
Okay. Managing as 2 bifurcation, double bifurcating. Yes, okay. It's good stuff. Yes. Okay.
Dr. Mufid,
Actually, I
I would
didn't.
like to ask you about this is a case of instantaneous involved in the LED. And it seems that the left main is not disturbed.
Yes.
Is there a role for a non-coated balloon in such complex case? For example, you can do balloon dilation for incentric node of the LED and you set circumference and you can manage or you can end up with a single stent.
Yeah, I think it's
Excuse
very
me.
similar to the case that we have seen before. So there was
I need 5 minutes.
you cannot treat it without touching the left. So it's actually exactly the same. So we have lesion at the ostium of the LED, a lesion at the ostium of the diagonal not the clarification, and the lesion with 1 or 3 letters which are okay, and the observation. So we know that touching stents is not optimal. The risk of stent thrombosis is very high. We stopped doing that after the case we had in our lab with a young woman who was a perfect case for this stenting, who had stent thrombosis at the age.
Okay.
So we stopped.
I think here one of the most important issues I myself I will do this stating as you are not doing.
Okay.
Because my concern here not the immediate angiographic result you are going to have in the CAT scan. This patient cannot be aggressive in stent receivers. So I try to put the least possible amount of stent in this section. So this stent is a very appealing idea to leave the left main beam, and you have a very wide angle, it's almost 160 angle. So this is favorable for this stenting, and we spare this safety.
And actually, in this standstill, it's a diagonal or ramus, it's involved. It's like that. So that's why I said go for V. I adjusted the V. This is SKS, but I adjusted the V. It's V now. Okay. I did deploy it. It's not SKS. As you can appreciate here, the ramus is still displaced. There is a balloon is inside, and have it like that, and then inflating the balloon and doing several predilatation, then stenting. This is a stent in the, took a stent also in the ramus. And then,
7 French or 8 French?
Yeah, 7 French, yeah. Then tracing with 3 balloon, and then adjusting with post dilatation with 3.5 in each of them, and this is the final result, which is excellent at that time. The follow-up of the patient, this has been done 18 months ago. He's asymptomatic for 15 months. I saw him 3 months earlier. Stress test was negative after 1 year. He stopped smoking only for 8 months, but recurred despite my advice on full medical treatment because he was not compliant before, but now he's compliant on full medical treatment. So my conclusive points in this case, that STEMI patients with shock and complex multi-vessel disease better to be managed by stage procedure if blood pressure improved after the culprit. Complex bifurcating lesion, this is a complex one, of course. Bifurcating lesion should be managed with patients and follow up the guidelines as much as you can, because V-standing here, I think it was a very good option without complicating the left main. Left main equivalent case managed by heart team, because we had the heart team. I didn't do it ad hoc. And explication of the procedure and possible consequence to the patient, because I told the patient that he will re-stenoze once again. And then he told me, no, I will go for surgery if I failed for the second time. So thank you very much.